Congenital diaphragmatic hernia, CDH. Anatomy of the diaphragm. Anatomy of diaphragm. Functionally, the diaphragm muscle and tendon separates the thoracic cavity and organs from those of the abdomen and is a powerful aid in respiration. Congenital diaphragmatic hernia includes Bogdalik's hernia, Morgagni's hernia, diaphragmatic eventuation, and diaphragmatic tendon herniation. Congenital diaphragmatic hernia and gender. Males are more affected than females with a ratio of 3 to 2. Bogdalik's hernia. More common in children presenting with respiratory symptoms. Possible to appear in adulthood and usually related with acute digestive problems. Due to its acute presentation, it often requires emergency surgery. It is best treated by laparoscopic approach. It is more common, 98%. Bogdalik's hernia at the foramen of Bogdalik, posterolateral in the diaphragm. Absence of the pleuroperitoneal membrane. Radiograms for Bogdalik's hernia. Morgagni's hernia. It is either right or left anteromedial defect due to a defect between the sternal and the costal portions of the diaphragm. It is less common, just 2%. The anatomy of Morgagni's hernia. The foramen of Morgagni, anteromedial. The defects between the sternal and the costal portions, 2% presentation. X-ray posterior anterior view of Morgagni's hernia. Morgagni's hernia lateral view. Diaphragmatic eventuation. High position of the diaphragm due to lack of muscle or nerve function. The nerves or muscles may not be well formed or may be injured. The muscles doesn't contract, causing its abnormal position and compression of the lung, causing dyspnea and respiratory problems. Congenital damage or dysfunction of the phrenic nerve present since birth. Acquired due to phrenic nerve injury by birth trauma, chest surgery, and rare tumors of the chest. Diaphragmatic eventuation. The diaphragm is flaccid and goes up in the thorax. Elevated diaphragm. Diaphragmatic central tendon defects. The rarest form of congenital diaphragmatic hernia, often associated with massive pericardial effusion. It presents unique challenges to the pediatric surgeons. Diaphragmatic central tendon defects, central tendon defect present. Problems of congenital diaphragmatic hernia. The contents of the abdomen, stomach, intestine, and or liver herniate into the chest through the diaphragmatic defect. This will lead to limited room for the lungs to grow. The compression leads to pulmonary hypoplasia. This herniation can lead to reduced pulmonary blood flow, pulmonary hypertension, asthma, gastrointestinal reflux, feeding disorders, and developmental delays. Typically, congenital diaphragmatic hernia occurs at about 10 to 12 weeks gestation. Antenatal diagnosis depends on ultrasonography. CDH can be treated antenatally in well-equipped centers. CDH can be unilateral or very rarely bilateral. It can also be life-threatening problem. The symptoms. Some patients are asymptomatic, tachypnea, or oxygen hunger, feeding problems, and poor weight gain. The signs may be accidental discovery by X-ray, maybe nerve injury or compression, maybe chest wall deformities, maybe missing ribs, maybe poorly developed lungs, maybe gastric volvulus, maybe vascular abnormalities, maybe congenital heart diseases, maybe renal abnormalities, maybe musculoskeletal defects. Investigations, chest X-ray, CT scan of the chest, and ultrasonography. Radiological observation of the diaphragmatic movements with breathing. Normally, the diaphragm moves down with inspiration. A paralyzed diaphragm will move in the opposite direction, upward in the thorax. The position of normal diaphragm during inspiration down and expiration up. Medical treatment. No role for curative medical treatment. Indications of surgical treatment. Two or more pneumonias on the affected side. One life-threatening pneumonia. Inability to get off mechanical ventilation. Respiratory distress related to abnormal motion of the diaphragm. Surgical treatment. Reduction of the contents and closure of the diaphragmatic defects. Diaphragmatic plication for cases of eventuation and tightening it with sutures to flatten the diaphragm muscle. This procedure doesn't repair the function of the diaphragm. This can be performed with open versus minimal invasive techniques and approached through the chest or the abdomen. The prognosis in the United States of America, the survival rate is approximately 50%, depending on the severity of the CDH and associated abnormalities. In the United States of America, the morbidity and mortality remain high despite the advances in neonatal intensive care with an overall 1 year survival estimated at 42%. Good luck and best wishes.